All right, welcome to ASCP's Our Experience. We're here today with our CEO, Chad Wers, and Tom Hansel. And today we're going to be talking to Dr. Delon Canterbury from the great state of North Carolina.
Yeah, I knew that.
Who's not in North Carolina right now. Delon is hung up in an airport, so we're going to make the best of this, but might see some passerbyers as he's talking here and there. They're going to try to get on the podcast. Everybody wants to be on.
Everybody wants to be on.
And they're going to try to what do they call that when you're photobombing? They're going to video bomb us here. But welcome, Dr. Delon. Thanks for joining us today.
Absolutely, guys. It's a pleasure to be here. How are y'all doing?
Doing well.
Doing fantastic. Enjoying the day. So we like to get started by kind of getting to know you personally and kind of getting your origin story. I know you're a board certified geriatric pharmacist. I know that's your concentration, and you've got your own company. I'm going to say this right, geriatric pharmacy, or how do you say that? Geriatrics. Just a spin on the word geriatrics.
That's right. That's right. Geriatrics.
I like it.
Well, tell us your origin story, kind of who you are, how you got to be where you're at today.
Yeah, I'm happy to. Thanks, guys, for having me on. I started as a community pharmacist working with Walgreens after graduating from UNC School of Pharmacy back in 2014. And, prior to that even happening, my grandmother actually was the one that was the story behind geriatrics, where her dementia had just taken a turn for the worse, and we didn't know why. I was, finishing up undergrad. My parents were originally from New York and thrust into caregiving, where we had to move my granny Mildred from an ALF up there down to Georgia, where I've grown up, and where our family is today. But we didn't know why she was getting worse. She was confused, she was wandering, super irritable. And it came down really to a Rite Aid pharmacist who did a review for her and advocated for deprescribing. I mean, it took 4 months of caregiving hell to try to figure out why she's sundowning, why she's getting worse. And one pharmacist advocated for that, which inevitably saved her life. In calling up the doctor and discussing, and it was an antipsychotic. It was an old school one. It was Ziprasidone, used to manage her symptoms, quote unquote. But this was a medicine, we trusted and just thought, this is a part of the care. But seeing, again, my parents thrust into caregiving, it took us 4 months to realize, hey, this was the cause of her issues. So we got that med tapered in 2 to 4 weeks, and Granny Mildred got back to her kind of normal baseline mild dementia self. And it was a huge win for the family, but it always stuck with me because, how many people don't have access to someone to advocate like that, or don't even know where to turn to ask the right questions? And of course, this was a medicine that was prescribed by the medical director. So who are we to think that's the wrong decision? So that seed always planted in my head when I went into the community, worked for Walgreens in a primarily rural population in Henderson, North Carolina, and found out, wow, I don't know a damn thing about geriatric medicine or pharmacotherapy. I didn't really learn it in school. I didn't do any rotations. So I decided to get my BCGP while I was in a community setting and studied for it and took the exam and passed out. So I got that in 2017, and then my eyes opened, right? And prepping for that book, studying for that exam, and I was like, wow, I'm missing all types of anticholinergic stuff. I'm missing GDIs, Beers List drugs. And I realized, you know what? We all need a community advocate for this, and that's what inspired me to start geriatrics in 2020.
Awesome.
It's, there's a lot in there. Like, the first thing is I want all the deans of all the colleges of pharmacy to listen to just that 5 minutes, because it's such a recurring theme to hear students talk about, I didn't get anything on geriatrics. And it doesn't, 25 years ago when I graduated from pharmacy school, and I was like, wow, they didn't really have a geriatrics program. It was important, but it wasn't nearly as important as it is today.
Right.
And you'd think in 25 years that the schools would be like, all the people are old and they're all on medications.
It's growing
We should be
rapidly, yeah.
teaching this a little bit more. And some of them have not. Even my alma mater, Cincinnati, still sort of blends their geriatrics into their therapeutics courses. It's not standalone. It's not highlighted. And, we still have that. So kudos to you for, first of all, taking the initiative to go down that road and get your BCGP, but also highlighting a story. And obviously it was personal to you, but so many people are going through that every single day. Some of them have an ancillary person that they can reach out to that can get them in front of a pharmacist that can do a review like the Rite Aid pharmacist did. But most people can't and or don't know how, or don't even realize that service exists.
Yeah, I mean, when I think about community pharmacists, they're either super busy, where they just don't have time to even, look up and even do proper consulting, or they're in a rural area where maybe they don't have time, but there's no incentive or reimbursement or direction from their corporation to say, take time to deprescribe. In fact, I would think that some corporations probably don't want their pharmacists to talk people out of taking medications, but you've taken this to a whole another level. I call it patient consulting on the highest level, if you will. I mean, I know you have a term, deprescribing accelerator. Tell me kind of what that means.
Absolutely. Our Deprescribing Accelerator is this really in-depth coaching program I've developed. And starting this company, I realized not only should pharmacists become deprescribing advocates, but why not empower other clinicians of the team? So that includes, of course, our social workers, our care managers, nurses, and of course, doctors, prescribers as well, along with pharmacists. And I feel we should have a community of deprescribing champions. So in me creating my practice, kind of going through the pitfalls of starting a business, I decided to create the Deprescribing Accelerator to coach people using this kind of hybrid in-depth approach to get people not only some quick tools and references to start the dialogue, but to also build a cash-based practice about deprescribing and putting it into their model. So I started this about maybe 3 or 4 years ago after starting the company, because I realized we all need a deprescribing advocate. So why not put what I've learned as my best practices in a pretty easy to follow format where we have 10 live taught classes that qualify for 15 hours of live CEs. And of course, this is a nice small cohort. We've got geriatricians, social workers, nurses. We have that IDS approach that we know the healthcare system needs. So we can learn from each other and then also share the wins around deprescribing for dementia, for opioids, for polypharmacy and herbals or OTC meds, along with accelerating the use of genetic testing for our older adults, right? So I believe they all can be augmented from multiple players in the field. So that's where the Deprescriber Accelerator comes into play. It's a year-long coaching program built for all clinical professionals to really understand the roots of deprescribing and get to what I love, what matters most, the 4M's, aging-friendly mnemonic. So it's been a blast ever since.
So Delon, from your experience doing that, because we talk about pharmacists and talk about the education that we're kind of frustrated with that they don't get as students. Is that the same for medicine? Do they not have formal geriatrics, for primary care? Obviously, if they become a geriatrician, I'm assuming they go through a stronger process, but that's almost akin to getting your BCGP and becoming a PharmD. So, but does the general practice physician also not kind of find their way to geriatrics? I know they don't know anything about meds, but that's step one. Do you find that?
Yeah, I do find it.
It's interesting.
The frustration is there. Again, you find everyone in geriatrics already has that personal story or embedded passion as to why they're getting into it. But we have less and less geriatricians. They're one of the lowest paid physicians in that field. Not to mention, again, I think we're not exactly using pharmacists to our top in this space to help them kind of bridge some of those knowledge gaps when it comes to polypharmacy and drug-drug interactions in the geriatric realm. So yeah, man, I hear it from speaking to clinicians who who share that frustration in the curriculum. They're not learning about this. They're not learning about deprescribing at all, let alone barely the geriatric piece. And that's why it honestly feeds to the problem of specialty prescribing cascades today. You know, that's why nephrologists only think about nephrology and cardio and the heart. They don't think as the holistic older adult who may not bode well with that 80 milligram furosemide. So that's kind of the mindset I see across the board, even from nurses who sometimes get shut down when they want to advocate for more holistic healing from other prescribers. They deal with that ego battle. So that's why I feel it has to be an IDS kind of team-based approach to really, again, augment better care for the future.
That's awesome.
So you mentioned pharmacogenetics or pharmacogenomics. Tell us kind of, again, what you're doing with that and what your experience has been so far.
Yeah. So, when I started this practice, I wasn't sure how to mold it. And so PGX was kind of my main kind of selling point or high value package point. And for me, it was bit on the angle of having communities that don't have access to this type of information have it. And so having a trusted messenger, as you can see, I'm a Black pharmacist. And so bringing that to communities of color who otherwise may not understand why some of these meds aren't working for them was one of my big moving factors in becoming a proponent and PGX consultant. Because as you know, a lot of these meds were designed for generally white males, right? Mm-hmm. So let's bridge that gap and kind of give people another lens of, you know what, that's why that codeine failed, or that's why I didn't do well on that antidepressant. And it's even worse where we're dealing with an older population where this technology wasn't out, right? It just wasn't really available or freely accessible. Now, we've got TRICARE, we've got Medicare, we've got Medicaid in certain states, and commercial insurers that will pay for this if they meet certain qualifications and whatnot. But my mission was to bring this to the community that I felt needed it most. So I started advertising for PGX as a part of my cash-based consult. And so I would do it as a kind of a 6-month or 12-month package. And again, be available if providers are considering switching therapies or if patients are already having issues or hypersensitivities to certain drugs. So it really sheds a wonderful light that I think patients, again, didn't even realize existed, let alone older adults who are going through this maze of medications.
So, Delon, that again, there's so much depth and wealth in what you just said. But where do you see the wins right now for getting people either to pay for it cash or getting some payers to pay for this? And then maybe talk about the challenges. I think the question I wanted to ask, but I want you to go through that piece first, is when you do somebody's genetic testing and you find out that they can't take a drug, let's say, or they shouldn't be on a particular drug, how often does the insurer push back and be like, oh no, that's the one on our formulary. If you're going to switch it, they're going to pay a higher copay? Or, how much of that goes on when you get into that detail? Sure.
No, that's a great question. For me, especially, a lot of my patients are already coming with this mindset of, I'm sick and tired of being sick and tired of going through this maze.
Right.
So they usually are getting whatever they want. And I'm just providing the evidence base behind why this is a better option. I think a great example, I had a patient with dementia who's always had chronic suicidal ideation and anxiety and depression. And I advocated for the family to get PGX tested through their health system, not through me, because it would be a little bit cheaper. And the doctor ignored that recommendation. So they just went ahead and tried Prozac 10, and the woman ended up having a physical attack on her caregiver, and the police had to be called for her to be subdued, which she regretted later on. And we ended up, unfortunately, having to do the test retrospectively, and we were able to see that she was a poor CYP2C19 and 2D6 metabolizer. So this drug would be completely contraindicated. So how much hell did that patient go through where a simple recommendation I made, which could have been covered, and it was covered, it just wasn't done. And I think that's the frustration is The barrier is we do this only after the harm has been done. We're not doing this preemptively, and insurers are arguing against that because they don't quite see the return from their clients, and that's why a lot of them just, frankly, you have to fail 2 or 3 drugs and blah 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 for it to be paid for. But this again was a significant harm to the caregiver and to the trust, and now they had to end up using another drug altogether, but we could have avoided that mess had we done this in the first place. So it was a win in a way, but it didn't have to go to such lengths to be such an experience for her. But in terms of your direct question about, formulary changes, med switches, at this point, the providers are just begging for some support, right? They just need someone to guide them. Look, I've tried 3 of these meds. Can we work with something else nearby? And you have a nice, clear-cut, pretty PDF report that I cross-checked with the med list. It just makes it the aha moment even better for the family and for the provider afterwards. And then they have a report for life that they can use.
Right. Absolutely.
Do you think that there'll come a point where I've always, I look at medication use and I'm like, it's expensive, it's complicated, and it's like the only thing we purchase as people that we don't get a user's manual for, and that user's manual is a pharmacist. But like, do you see a point where a company, take Eliquis, says, hey, you're being prescribed Eliquis, we're going to pay for a genetic test because we want to make sure it works for you, or we want to make sure you're not going to be at risk because of it. Do you think that the companies will ever take that step? And it almost comes with the drug? I have to believe, like maybe in oncology they do that. They would have to.
You would think it would just be a safer, cheaper, cost-effective solution. I mean, at the end of the day, I know our government's not very good at being proactive.
Yeah, right.
But insurance companies, there's financial incentive for insurance companies to do the geriatric or genomic testing just to make sure they avoid having to try and do multiple different medications.
Yeah.
Absolutely. Especially when it's hitting their bottom line. I'll share an example. Bristol Myers Squibb helped to develop Plavix, right?
Yeah.
And in 2021, they had to settle an $865 million lawsuit because they failed to share that they needed to genetically test people specifically of Asian or Pacific Islander descent. This was the Attorney General of Hawaii who noticed that his people or her people were actually dying after taking the medication Plavix. So that happened in 2021, didn't get much news, but they had to pay that. Now, mind you, drop in the bucket, but that led to momentum where now FDA is requiring new drug makers to report on PGX drug interactions for future drugs going forward. The movement is slowly brewing, and now pharma has to report on other significant CYP3A4, et cetera, interactions. I was going to go somewhere with that. It's definitely happening. Now, to preemptively test, we already have FDA guidelines around PGX actionable drugs. The most quoted one, of course, is Plavix, but we do have guidelines that coincide from the FDA, for your antidepressants, your anti-coags, certain statins.
Yeah.
So the guidelines are out there. And it's going to become normalized in more time.
Interesting.
Also, that's what I wanted to say. There are tons of more data out now. Like before, it was kind of new and nascent. Like the VA has tons of PGX guided studies. We've got a couple independently done ones as well. I'm actually partnered with a genetic researcher at VCU who specifically focus on calcium channel blockers and how there may be PGX actionable markers specifically within African American populations to kind of see why are there such variances between different classes.
Right.
So it's there. I mean, the All of Us campaign, which was funded by the Obama administration, was enrolling close to 1 million people of different diverse backgrounds to PGX test everybody and see what's actionable. So you're right, Chad. It's definitely in the oncology space. It's becoming, of course, the zeitgeist in a way, but the funding piece is always where there's a little bit of a scant look with the insurers And
course.
the main argument I'll share is for them to see a return, they need to see people in their plan for at least 18 months. And if people are changing plans every year, they don't feel justified in paying for that. Although a minute $300, $500 cost, that CMB, that Medicare bill is going to look like 9,000, 10,000 if you're billing. But even though it doesn't go to the patient, the real out of pocket for cash is 300, $500. So to me, no brainer. But when you bill a lab, it's significantly more.
Yeah.
So I can see why there's a hang up.
Yeah. It seems typical with
So-
insurance.
So legislative wise, when we talk about Medicare and Medicaid, anything happening on Capitol Hill regarding PGX with Medicaid and Medicare?
I think at the start of last year, unfortunately, there was a bill. We were trying to get more reimbursement for our labs to get, I think there was a 50% cut on their reimbursement. So unfortunately, that cut has sadly knocked a lot of the little guys out the way. So to my knowledge, it's a little bit deadlocked at the moment, other than that law passing at the beginning of last year. So basically less labs to do the testing, less reimbursement to do the testing, but nothing I quite know as of now that's in the pipeline. But at present, though, depending on your state, original Medicare does indeed pay for it if you're on certain meds or have failed certain meds. TRICARE, the VA pays for it. It's more about just asking. What I'm finding, though, is not every VA is like as savvy, and some are more partial to using it than others. And Medicaid use it. For instance, in North Carolina, if you have a genetic counselor write off and say you need this, you need a genetic counselor to be approved for Medicaid billing here in our state. So there's nuances from state to state. But I mean, commercial insurance, there's a small copay, but at least for those who have failed therapies or have had harm, you can ask for it and you can see if you can get it covered.
That's cool. Well, I mean, pharmacogenomics is one tool in the Delon user manual that you go out and do for patients. Where else are you seeing wins? Where are you seeing successes? Billing your services, getting paid, working with people.
A new frontier I embarked on last year was becoming a corporate partner with the Aging Life Care Association. And this is something I've always taught my students who take the Deprescribing Accelerator, is to think about non-traditional partnerships. And one of the best ones I found was working with these private pay care managers. Like, guys, aging is not just a doctor and a nurse. There's like a huge spectrum of aging, from PT to OT to ST to massage therapist to senior living, you name it. And so in becoming a corporate partner, I was able to get a lot of referrals from being in the room with these care managers. Some of them are gerontologists by trade. Some of them are nurses. Some of them are social workers. Aging Life Care Association has been an amazing partnership. So I started educating them about the power of what pharmacists can do, and especially in this kind of concierge world. And they're all private pay. So I'm not hitting those potential cost barriers where everyone's expecting it to be covered. So they already have patients that are paying for this service out of pocket. So it's a no-brainer for them to make a referral if they're seeing their clients with falls or polypharmacy or general concerns about their quality of life. So that was my first time doing that, and that's led to some B2B contracts and to ongoing referrals to date.
That's awesome.
And of course, better patient care. Yeah,
Right.
Yeah.
Everyone wants a pharmacist.
I mean, just another example of how, if you're frustrated with retail, or you just don't enjoy being a dispensing pharmacist, Delon's created a whole new pathway of how pharmacists are going beyond the counting the pills and getting reimbursed, for that,
Absolutely.
for those, clinical consulting services.
Innovator.
Yep.
It's awesome.
That's fantastic. What's next? Anything on the horizon? Anything you want to tell us about?
Yeah, part of why I was here was to showcase this project I had going on with Duke Clinical Translational Institute and the US Deprescribing Research Network, along with AME Zion churches, which are traditional African American churches. And so they awarded us a mini grant to bring deprescribing workshops to these church communities. There's about 17 different parishes. And that was my project for the last year and a half. And so we were going for some new funding, but unfortunately didn't get renewed for it. But part of why I'm here at American Geriatric Society was to highlight some of the results of that work. And so in doing these community workshops, I mean, we had over 200 people on like a 2-hour Zoom webinar. About 123 submitted their patient attitude towards deprescribing surveys. Overwhelming majority were interested in deprescribing. Overwhelming majorities found that cost was a barrier and that they would be interested in deprescribing. But I think for me, the biggest win was, again, bridging access to experts that otherwise don't exist, right? How many people just feel like they don't have enough time to share their concerns in a medical office? We're giving people a safe space to talk through what harms or what benefits or what wins they've had in their pharmacotherapy. And, do they feel they can openly speak to providers about this? Do they feel safe? Do they feel, side effects can actually be a topic of conversation? And so the whole goal of this was to create a culturally sensitive framework for primarily a Black audience and caregiver audience to kind of bring some tools to the PCP and say, hey, look, we've met with Dr. Canterbury and his team, and, these 2 drugs are things we could probably taper. So I was able to present some of that info at this symposium and inspire more physicians to get into this phase, of leveraging pharmacists in a different light and meeting people where they are, which I think a lot of healthcare is missing, is leading with empathy and leading with meeting people that relate to them, right? That look like them. So you're not coming in a silo. So what I learned from being a part of this network was man, we have tons of data with, acute settings, but we don't really have strong community-driven clinical studies. And that was what I was told was something that was unique about our work. And I'm very proud of that.
No, that's awesome. It's fantastic.
And you should be.
Yep, absolutely.
Well, Delon, this has been great. I appreciate you taking time. I know you're busy, traveling, man, and all over the place, but I've learned a lot. I'm inspired.
No,
this is fantastic.
And apparently everybody's beating down the doors to get to Delon. So
you guys are funny, man. I so appreciate it and appreciate all you guys are doing too. There's a lot going on in the world right now, and thank you guys for just spreading the light of what pharmacists can do in this profession.
Well, thanks for being a consultant pharmacist. Thanks for being a pharmacist that works with people directly and does medication management.
Concentrating on geriatrics.
It's a big deal. It's a big deal, and we need more out there doing it, and you're leading the way, so we appreciate it.
Appreciate you guys. Thank you.
Thanks, Delon.
Thanks, Delon. Travel safe. And thanks, everybody, for listening, and to tune in next time for your next Our Experience podcast.